Good evening, everyone. My name is Claire Simpson, and I'm the Manager of Alumni Relations at the Leslie Dan Faculty of Pharmacy. I am delighted to welcome you to Mental Health for Healthcare Workers, Steps to Solutions. Tonight's panel is brought to you by the Lawrence S. Bloomberg Faculty of Nursing, the Factor and Wentash Faculty of Social Work, and the Leslie Dan Faculty of Pharmacy. Before we begin, I would like to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Tonight's discussion will explore issues impacting our healthcare workforce in the hopes that we can make steps to meaningfully improve conditions for some of our most essential workers. Leading the conversation is Dr. Rochelle Ashcroft, Associate Professor, Factor and Wentash Faculty of Social Work, cross-appointed to the Department of Family and Community Medicine at the Temerity Faculty of Medicine. Dr. Ashcroft has 14 years of social work practice in healthcare, including hospital and community organizations. As a health system researcher, Dr. Ashcroft has particular interest in nurturing organizational and policy contexts that support the delivery of team-based primary care, patient-centered virtual care, interprofessional collaboration, and strengthening social work practice in primary care and other healthcare settings. Over to you, Rochelle.
Thank you, Claire. I'm so pleased to introduce our three panelists. First, we have Dr. Jamie Keller, who is the Associate Dean and Associate Professor at the Leslie Dan Faculty of Pharmacy. Dr. Jamie Keller's clinical area of expertise is mental health and addictions. She teaches in the neuropsychiatry and health systems courses at the Leslie Dan Faculty of Pharmacy at the University of Toronto. Dr. Keller has received numerous teaching awards, including the President's Teaching Award and an Early Career Teaching Award from the University of Toronto and the National Award for Excellence in Education from the Association of Faculties of Pharmacy of Canada. Her research is in the field of health professions education with a specific focus on professional identity formation. Next, we have Dr. Elizabeth Peter, professor at the Lawrence S. Bloomberg Faculty of Nursing. Dr. Elizabeth Peter's research focuses on examining the political dimensions of nurses' ethical concerns and understandings, with her scholarship reflecting her interdisciplinary background in nursing, philosophy, and bioethics. Recently, she has examined the ethical concerns of nurses during the COVID-19 pandemic and has ongoing research examining the ethical and social dimensions of the patient, family, and clinician experience as care transitions from hospital to home using new monitoring technology. She serves as an associate editor for Nursing Ethics, the chair of the Bioethics Expert Panel of the American Academy of Nursing, and the chair of the Ethics Review Board at Public Health Ontario. Prior to working at the University of Toronto, she worked at the Centre for Addiction and Mental Health as both a staff nurse and as a nursing coordinator. And finally, we are so pleased to be joined by Dr. Javed Alou. Dr. Javed Alou is a community family physician and educator on integrated physical and mental health at the Center for Addiction and Mental Health and Trillium Health Partners. Welcome to our three panelists. The purpose of the panel today is to explore issues impacting the mental health and well-being of our healthcare workers and steps that can be taken to work towards sustainable solutions. Today, we are talking about people who are usually busy taking care of others, yet the mental health and well-being of the healthcare workers themselves is so very important. Just to give you some context, burnout, which is characterized by emotional exhaustion, depersonalization, and diminished professional achievement, is a real concern. Research published in 2021 on behalf of the Ontario COVID-19 Science Advisory Table and Mental Health Working Group showed that the prevalence of severe burnout in hospital-based healthcare workers was 30 to 40% in 2020, and by spring 2021, rates of burnout were greater than 60% in Canadian physicians, nurses, and other healthcare professionals. As well, a new study published in International Social Work by Dr. Ramona Elagia and Dr. Esme Fuller-Thompson, who are both faculty members here at the University of Toronto, demonstrates that social workers have experienced depression and anxiety at alarming rates during the pandemic, 4 times higher than general population. Now let's hear from our panelists who will help us better understand the problem. To start, I'm going to ask each of our panelists to tell us what some of the issues are that healthcare workers are currently facing. Dr. Peter, let's start with you. Recently, you have been conducting research on nurses' experiences of their ethical responsibilities during the COVID-19 pandemic. Can you describe to us what ethical responsibilities means? And talk to us about what you see as a key problem impacting the mental health and well-being of nurses.
Okay. Well, thank you so much for inviting me. I believe this is such an important issue right now facing our healthcare system as a whole. And I think as many of you would realize, there are many different ways of conceptualizing mental health and also ethics. My work is in ethics. So in our work and in the recent studies during the pandemic, we have used the work of Van Leer and Gastmans, who use the scholarship of Martha Nussbaum and others and Joan Toronto to really conceptualize what the ethical responsibilities of nurses are and to add some depth to this. And we know in part this has to be about using the best knowledge, skill, and judgment, but it's also very much about the relational elements of care. So when nurses are being ethical, if you will, they're not only caring for people, they're also deeply caring about them, which is a different orientation to people and their concerns and so on. So when looking at ethical responsibilities, I mean, if we were going to just use a layperson's term, we could have just said standards of care, but using a theoretical lens gave us some more depth. So in terms of mental health, however, there are a number of related phenomena variously labeled. There's moral distress, there's sometimes termed moral stress, and sometimes moral injury. And all of these relate in one way or another to the kind of negative moral emotions like guilt, shame, and so on that people experience when they can't meet their own standards, when their integrity is violated, and so on. Now, moral injury is a term that has increasingly come into the healthcare literature. Its origins are in the military. So it's a much more severe form of negative emotion, if you will. So in the military, it normally refers to the kind of injury, if you will, that perhaps a soldier would experience coming back home after perhaps engaging in a war crime, to be straightforward, perhaps witnessing something, or feeling pressured by a commander or the group to do something they would not normally do. And this is rather distinct from PTSD because it has a distinct moral component. And there has been some effort to bring this into the DSM, which as far as I know has not yet happened. But we also see this term coming into the healthcare literature, but it refers to quite the extreme end of this. So all of these things in some ways are related, and they're related to burnout, and they're related to compassion fatigue as well. But in ethics, there has been the tendency to want to foreground, if you will, values and integrity and so on, and how these are very important. So if we look at nurses, the one thing that has been commented on a great deal is that nurses tend to be in close proximity to patients, residents, clients, depending on context setting. And with that normally tends to make people more compassionate, but it also can be very, very stressful when things, when there's trauma, when things cannot go according to standard, if you will. So the long and the short of it, the challenges that we found in our work, The biggest stress factor, if you will, was because these nurses felt that they could not meet their ethical responsibilities in the way they felt they should. And that was deeply distressing. And this is not something I believe that is unique to nurses, but this is the group that we studied. In nurses, when there is not, usually it's the root cause is a lack of staff. Nurses tend then to prioritize their care around things that are life-sustaining, but they may miss fundamentals. Fundamentals of care, things like getting people up and walking, skin care, health teaching, and so on. And so this diminished sense of care is something that deeply troubles nurses. Some things that were specific to the pandemic, and this is in a lot of other research, is that nurses were very distressed that family members could not come in, particularly during times of dying and death. This was of great concern. Nurses in the community, they also talked about community services not being open, so their clients were without care that they required. So there was that kind of isolation. And with public health professionals legitimately focused on the pandemic, we also had the opioid crisis. So there are all of those clients as well that they were concerned about. And finally, the one study that we did, we focused specifically on long-term care, and we focused on registered practical nurses in long-term care during the height of the pandemic. And they were by far our most distressed group. They were working under conditions where they had no family members coming in to support. They witnessed an enormous number of people dying. They couldn't provide the kind of palliative care that they wanted. And so many of them, for lack of a better word, were simply gutted by what they saw. Many have left the profession. They felt terrible that they had betrayed themselves and the profession in their eyes, even though they were doing all that they could. They continued to go back into these nursing homes because of the commitment they felt to residents and so on. Many of them became sick themselves, and many of them now are living with some of the mental health consequences. So that particular group was the one that I think we came away being the most concerned with. Personal support workers, we did not study them, but I can assume that they would be equally distressed by those working conditions. So that's a nutshell, and I'll let you go to the next speaker.
Great, thank you. Dr. Keller, you are a mental health champion in pharmacy. Can you help us understand what occupational stress and burnout looks like in the pharmacy context?
Sure, thanks, Rochelle. And I think that many of the things that Dr. Peter talked about are actually translate well into pharmacy as a group. However, pharmacy is understudied, generally speaking, in healthcare. And certainly in this particular area, there's much less data looking at occupational stress and burnout in pharmacy specifically. That said, there has been an increase of literature relative to the pandemic. And so we do have data that is very much in line with many of the things that Dr. Peter talked about in nursing. I think that the pandemic has exacerbated a number of things that were happening in pharmacy, particularly community pharmacy, for a long time, and they've really just brought them to the forefront. And pharmacists over the last few years specifically have really had to step up to provide frontline care, which we've always done, but in the absence of access to other healthcare providers in communities. And that has been challenging. Pharmacists have been open longer and in person more than most other healthcare providers. And so when someone needed something, late in the evening, access to a healthcare provider, the pharmacy was there. Answering COVID questions, their phones were, impossible to keep up with. All of the vaccinations that pharmacists have stepped up to participate in and deliver COVID testing, as well as all of the work that pharmacists are doing with managing medications. And so some of the challenges around drug shortages, and when Dr. Peter talked about moral distress, we're seeing it in pharmacy in ways that we've not actually historically talked about it. Trying to determine who to give medications to when you don't have access to drugs and shortages, and having to triage that on the spot and figure out which patients you can substitute and which you can't, and how you can access medications that are in short supply and at various times come back and then disappear. A lot of challenges right now with robberies actually in community pharmacy. And that is extraordinarily stressful. And it really increases the amount of stress and burnout that folks are experiencing. And a number of ethical challenges around how do you manage and how do you stock your narcotics in the environment that we're currently living in, that's causing a lot of decisions and a lot of stress for pharmacists as well. In hospital settings, certainly we saw stress and burnout as well, but we saw it in different ways. Pharmacists often cover many units in hospital practices and have a variety of expertise. However, during the pandemic, they were often being pulled to units where there were more patients or there were sicker patients, and pharmacists were being moved into areas that they'd never worked, particularly to the ICU, where they may not have had training for a number of years, and the stress associated with learning, again, new practices, new team members, all of that contributed significantly to the stress that pharmacists and their teams were experiencing. So I think a number of different issues over the last several years, including additional scopes of practice, have really increased pharmacy's presence, particularly in the media. You certainly hear a lot about pharmacy. However, it has been stressful. We're seeing more people retire. We're seeing shortages as well. So I think it's been a really rewarding time to be a pharmacist on many levels, but a very challenging time as well. And I would say the workload right now is probably one of the biggest challenges that folks are trying to navigate, that's contributing significantly to stress. And unfortunately, we are seeing burnout. We're seeing it at, again, rates that are much higher than the general population and much higher than they've ever been. If you look at some of the survey data, you've got 80% of pharmacists reporting currently that they feel high levels of stress and or think they could be experiencing burnout. So these are things we need to start to talk about, but at a systems level, so we can start to figure out how to move forward, because it's not feasible for individual pharmacists to solve this problem on their own, nor should they be tasked with that.
Great, thank you. Dr. Alou, you bring the perspective of a family physician leader. Can you please explain what you see as some of the key challenges currently facing family physicians?
Sure, and I'll speak not only about family physicians in the community, but also what actually is the reality for a lot of other interdisciplinary providers in the community as well. And there's a lot of commonality in our needs and the experience of the last number of years as well. So we know the Canadian Medical Association did a really significant survey of family physicians and other physicians across Canada, and what they found is more than half actually did qualify for having burnout. So we're recognizing it's not only we're under distress, but actually there's a decompensation happening already by that stage. And so you worry about what this means for efficiency, efficacy, and sustainability of their work going forward. And we know that it's actually younger physicians and learners who were the most distressed. Female physicians were under extra distress and demands as well. And then family physicians actually ranked significantly higher than other specialties. And that has to do with some of the isolation that we see that occurs in primary care. And that applies to the nurses, nurse practitioners in primary care, and the pharmacists and all the other providers working in those contexts. There's a lot of relatedness and issues. And the solutions will also arise from recognizing the contextual issues that happen there. And as Dr. Keller spoke, we recognize there's issues at the individual, organizational, and systemic level leading to these conditions, and also the solution will be found in that context. So talking about the family physician component, we know that there's a significant shortage of family physicians. So in Ontario, 1.8 million Ontarians right now don't have a family doctor. We expect the number to be 1 in 5, so nearly double within the next 2 years. And we're also having a growing population. We had the announcement today that there's 1 million more Canadians, 450,000 coming to Ontario, will all need more care. So there's more demand simply because of volume changes. And when the system shut down during that lockdown phase of the pandemic, all that specialty care basically stopped for the most part. All that burden got shifted to primary care in the community to stabilize and maintain. As the shortages and backlogs and work, the wait lists continue in secondary care, all that work is still managed by primary care. We also have the long COVID adding on to that. So the Ontario Science Table described needing 250,000 excess healthcare visits per year because of long COVID, probably an underestimate based on our data. And that's largely going to be primary care again. So there's significant reduction in workforce, significant increase in population, as well as significant increase in acuity or complexity of population needs. So you're waiting for, the problem is just beginning to be seen, as what I describe it as. So we also look at the isolation fragmentation I spoke about. We know that when you're looking at, it's not just about being connected and talking to somebody, it's about actually having access to safety measures. When PPE or clean air came across in the beginning, or even now, it doesn't exist in most primary care community settings. So they don't have the security. As Shanafel talked about a lot in the papers on wellness and safety over the last couple of years, hear me, keep me safe, let me work is actually the early phases of being able to do the rest of their work in a sustainable way. And so we recognize these are areas that primary care and community care are really, really disadvantaged in terms of going forward, that will continue to add to their distress and burnout and capacity limitations. So I'll stop here.
Great, thank you. The next question is over to you, Dr. Keller. Some of your recent work has focused on resiliency. Can you talk to us about what resiliency is, why it is important, and how we can cultivate resiliency within the pharmacist practice context?
Well, I think resiliency is just one tool that we have to help to combat stress. And it's certainly something that I sort of think of it like a muscle. It's something that we all have, but we can all continue to develop and grow over time. And so individuals that are able to be more resilient and can build up their resiliency tend to be able to bounce back better from all sorts of things, stressful work environments, failures, even positive changes. And so resiliency is an important element to help combat or manage stress that we're experiencing in the healthcare workforce, broadly speaking, not just in pharmacy. That said, it on its own is not going to solve the problems that we're seeing, and it's certainly not going to be a solution for individuals that have moved into burnout or are significantly past the point of just working in stressful environments. And so it's not a Band-Aid or a solution that's going to fix many of the problems that we're experiencing. That said, I still think it's important. And I think it's another one of the things that we need to think about at an individual level. As individuals, we can build resilience, but we need to think about organizational resilience and system level resilience. And all of those things, when coming together, will help to ensure that we have a healthcare system that can continue to provide for the needs of Canadians. And I think some of the key components around resilience relate to things like connection, our ability to connect with others, our ability to connect within our teams, within our environments, and thinking about how can you build connection as an individual. That's important to me, the human, and I connect with different people in my own personal and professional life. But how do I build connection with my team, my healthcare team, the folks that I work with every day? So in pharmacies, those can be our pharmacy teams, assistants, technicians, but also other healthcare providers that we work with in primary care and in hospital settings as well. And how do we build relationships and find ways to have a connection to provide care to patients? We can also think about wellness. Wellness falls into resiliency. And the more we are able to build our wellness, the better able we are to be resilient. And again, self-care falls into this, but I'm always reluctant to talk about self-care when we're talking about occupational stress and burnout, because I've certainly been a participant in things where when we're talking about this, the easiest solution is, well, just work on some self-care and everything will be better. Well, self-care is important for all of us to be able to find and promote our own wellness. It's not the solution for systemic problems, though. And so although I advocate for folks to focus on themselves and to find time to do things that fill them up, it's not on its own going to be enough for us to solve the problems that we're experiencing, particularly in healthcare. I like the example that Christina Masloch, who's one of the big researchers in burnout, she uses the example of a canary in a coal mine. And she, describes this beautiful yellow canary that enters the coal mine, and it's singing and it's happy, and then it comes out black and covered in coal and soot, and it can no longer sing. And nobody ever asks why the canary made itself sick. Well, because we all know that it was the mine and the environment that it worked in that made the canary sick. Yet when we work in organizations and folks are stressed, we often ask, well, what's wrong with that person? Why can't they manage the stress? Why can't they figure it out? Everyone else can. And so we're quick to blame individuals. And I think we really need to move away from that. And we really need to think about, how does individual resiliency contribute to overall organizational resiliency, and what do resilient systems look like, and how do we start to move towards that by improving communication systems, by improving staffing levels, adjusting workload, And those are hard conversations that take resources. But I think moving forward, that's the resiliency that we really need to focus on. And it has to move beyond the individual, though that piece I still think is valuable to discuss.
Thank you. It's a perfect connection to my next question for you, Dr. Alou. I'm wondering, drawing on your system level expertise, how can we cultivate organizational practices where family physicians and other healthcare workers are well supported?
That's a great question. Perfect lead off from Dr. Keller as well. So recognizing exactly what you described, Jamie, was the reality looking at it's going to be organizational level, that meso level, which is almost the perfect place to start intervening on issues like this. Because we're actually working both upwards and creating the environment for people working individually in that context. So are we actually doing efforts, as Dr. Keller described, to actually make work easier to do, which is the whole point. People are coming in every single day. In Nova Scotia, there's an article in the newspaper just yesterday describing a 10% reduction in administrative burden commitment that they had within 3 years. And they're already well on their way to doing that in many areas of care that they're doing for primary care. So I think recognizing there are ways of duplication and workflow. So process mapping is exactly what organizations do. Our processes, we know, are incredibly cumbersome, way more than they need to be. And I think the investment would be in about process improvement for efficiencies that actually reduce duplication on staff, because our limited resource is the people working, not our computers, not our process, not the rest of it. And I think if we want to see sustainability, because we know we're having attrition at massive rates, we're not going to meet our safety quality targets if this trend continues. And so if an organization wants to see itself meeting a target within 6 months or a year, it needs to invest now in methods to enable their staff to be able to continue doing that work. And so there's a good business case argument to be made for why reviews of processes to reduce duplication and efficiencies can be done now. And as Jamie also talked about, the connections part is critical. Organizations either foster community amongst their team as well as amongst their peer organizations, or they hope that magically these things occur and it's a systems problem to solve it. And they wonder why people don't feel connected in organization or why they're not working in collaboration with their partner organization in primary care or in community care or in hospital care. And so there's opportunities to look at duplications. We're all suffering largely. If you imagine every single day, each worker spends how much time trying to connect to somebody else, a different organization, to get their job done. This is created work by barriers that we've erected. It's actually not a natural issue of care. And so we actually can look to see, can we streamline it? And that's nothing the individual should solve, which is what's happening right now. The social workers know stitching together this broken system is how much of the work. This is parts organizations can play a role one by one with their lead primary partner to get the job done for patients and clients. And that'll actually make people feel fulfilled, feel they have agency, and extend their efforts to the part that actually drew them to this profession, because it was not sitting on the phone all day or not paper pushing that drew them to do this work. And so you can actually make them feel accomplished and valued in their work, addressing one of the core issues we know in burnout is not feeling professionally satisfied. I know in the culture part is a big part of the conversation, embodying the reality of needs. So when I helped the Ontario College of Family Physicians create their new educational program at the start of the pandemic on mental health, substance use, and chronic pain, it was designed initially for educating clinicians on how to support patients' care in those areas. And that's what we were funded for. But we recognized that burnout was critical. We knew that you could not get people to learn new things that were demanding and stressful. We've been trying for 20 years to do that unless we addressed it differently. And so we did things differently. So every month we'd have hundreds of family physicians gathering together. The virtual technology helped that. But the conversation was explicitly different. We drew in people from different stages of practice, rural and urban, bringing them all together to help themselves be seen in their work and valued in their work in different roles. But also, not only would they speak about clinical content, but every single topic we had, whether it was alcohol use disorder or anxiety or chronic pain, we'd invite the panelists to speak about their lived experience with that disorder as well. So they spoke about, physicians talked about their alcohol use disorder when they were teaching about how they care for patients with it now. When it was anxiety, we had physicians talking about their anxiety as they learned to manage it in the process. So there was no separation of wellness from clinical care and learning. It was one entity. And we presented on this at the International Conference Physician Health that was held last year as well, because this was a unique, embodied, honest way of representing the culture and supporting our learners and our practitioners in their work. So I'll stop there and hand it over to the next question for Dr. Peters.
Great, thank you. Dr. Peter, what have you learned in your research about the sources of support and the types of social connections and collaborations that are important to improve nurses' mental health and well-being?
Oh, thank you. And I think I'm going to be doing a lot of repeating from Dr. Keller and Dr. Alu, because I'm going to be saying some very similar things. So even before I get to what our participants told us, I mean, I think the real solution is prevention. I think half of the mental health issues and half of the ethical issues would go away if there was adequate staffing. It's a huge problem, and it's just self-perpetuating, if you will. So, but in saying that, we did ask our participants what they found most helpful. Well, they found each other most helpful. So, and the team most helpful. So it was that connection, which the other panelists have talked about by far, hands down, even in the scoping review, each other, the team. They talked about family and friends being helpful as well, but they also said family and friends don't entirely understand what they're going through, and also a hesitation not to come home, if you will, and burden those family and friends with their issues. So that was huge. We asked them about how helpful it was to receive some of the mental health supports that were put in place during the pandemic. And we received some mixed reviews. Some said, okay, it was okay. But they felt that what they were going through was very specific, so somewhat helpful. Some spoke about some of their therapists they had seen in the past. That was useful. They also found it very helpful when leaders and managers made a point of going directly to the site of care. So whether it was the unit or the community organization, they found that very valuable to have that leader or manager there to share in some of the issues. So that was useful. They also talked about some of the things, the self-care, again, and I have the same anxiety around the self-care because we don't want to place the problems of the system on individuals to solve. But some of them did talk about the usual list of exercise and distraction and meditation and television and so on. So there were those things as well, but it was the big one was the team. I should also add there is some evidence. There are people who have studied various interventions to lower moral distress. There isn't a strong evidence base for anything, but what they have found is some educational interventions are helpful, where people can learn how to label what they're feeling, reflect on what they're doing, to find strategies to speak up in organizations, sometimes clinical ethicists that are embedded in various places. That has been found to be helpful as well. Building what we would call moral community helpful, where there's a shared ability to talk about moral issues and so on. Again, there's not a strong evidence base, partly because context varies so much. And moral distress has been defined in many different ways, but there is that as well. But I lean heavily on the prevention side to be the most important.
Great, thank you very much. Bringing the social work perspective, one of the challenges highlighted in a survey of more than 2,000 social workers conducted by the Ontario Association of Social Workers and published in the British Journal of Social Work was the heightened level of isolation experienced by social workers after shifting to working virtually from home during the pandemic. So very similar to what the others have said. In some of the recent work that I've been doing, some social workers and primary care teams have noted that this isolation continues, which is a bit concerning, and really emphasize the need for regular and meaningful collaborative interactions with other members of the team. And for social workers across different healthcare settings, clinical and peer supervision is an important source of support and capacity building. So I'm going to shift and ask a few questions about the role of technology. Dr. Alu, what role do you see technology having in helping to alleviate some of the strain that family physicians are currently facing? And are there any examples from your experience where technology is helping to bridge this gap?
Sure. And so technology is always one of those things, like any tool, that both hurts and helps. And so we see that very much in healthcare as well. So we know the rise of Zoom, right? So connected providers isolated in small clinics able to discuss cases, with each other and with patients who couldn't come in far better. You had far less no-shows for difficult mental health and substance use care issues using technology than you had without it. So efficiency was improved in certain ways. Their accessibility is improved for patients that they couldn't actually get to see otherwise. But it also made it easier for them to add hours, which was good when there was a demand. So they could say, I'm working from home. I'm not spending 2 hours commuting. I'm getting the work done and setting those 2 hours. But it also meant the boundaries were blurred. And so their separation of their self-care time and their working time also got reduced in that process. We also know what Zoom overload feels like all of us right now in this process. So there was good and bad in that process. We know that these issues around patient portals and email and communications also improve connectivity with patients and with our coworkers, again, with extra volume burden. But the main issue we know is that the EMR systems are not designed for actually supporting care. It's more of a documentary system for the most part, which creates more workload and more medical legal risks largely, but without actually improving outcomes sufficiently for the burden we're facing. So we know there's a need and an opportunity to improve the efficiency there. But what I think we most want technology to be able to do, what actually is beginning, but it's not a mature state, is to connect us to each other to get our work done, to connect patient care, for example, knowing who's available, how long to get them seen when we need help. These are things that we know are efforts in the Ontario Health Team and other methods of engagement, but we know these are not there yet. So right now, technology allows a channel for connecting. Volume is a big demand that it places on us. The returns for that, we haven't yet been able to show at scale reliably. It's usually the individual connection that's helped solve problems for the most part. So I think there's challenges, but opportunities with technology going forward. There's also, as we know, self-care apps for both patients and providers that definitely have, some of them really have good evidence bases that we would use and recommend. But I think the biggest opportunity to see technology is our paradigm of how we provide care fundamentally will need to shift. So increasing health workforce will certainly be a part of it. But our assumptions were also a pretty old system, which is, we're the experts on care. We provide care to patients. I think that the paradigm is going to shift the technology, where it's about patients and people living their lives, and how do we as a system in different ways support them in getting the care and quality they want, which is a lot about using technology to connect with them, inform them, and help them do self-care and adherence and all the rest in care, where we come in where needed and don't fulfill what gaps in technology are actually forcing us to fulfill right now. So I'll stop there and hand it over, because I know there's a lot more to add to the conversation as well.
Great, thank you. Dr. Peter, next question is for you. Based on the research you have done, what are the benefits of providing virtual care to people in their homes to improve both patient and nurse satisfaction?
Okay, yeah, thank you for the question. I've been involved in a couple of major studies as the person looking at patient experience, some clinical trials looking at people discharged home post-surgery and what their experiences are with virtual care. And so these trials involve people going home wearing monitoring equipment, and they connect with specially trained nurses, usually on a daily basis by video, to talk about their ongoing needs. They often take photos of their wounds, their incisions, and so on. So, and in these, we have found that there's very, very high patient satisfaction and family satisfaction. I think it mainly because they feel there's always a point person. If there's a problem, they can contact the nurse. The nurse is working with a number of physicians. And so when things need to be changed, orders need to be changed, or some other aspect of their care needs to be changed, that can happen very, very quickly. So as opposed to being at home and feeling anxious and not knowing whether to go to the ER or not, there's a point person. And for anybody who has taken care of someone at home, you'll realize it is absolutely confusing who to call normally. And when the first point of care is the ER, that is just not ideal. So there was very high satisfaction with this. And during the pandemic, of course, many of the clients at home, they were happy not to have to come into a hospital so that they wouldn't, perhaps become more ill when they were there. The nurses and the physicians, by and large, were quite satisfied as well. They felt it was a great way to work as a team. I know the nurses felt that their expertise was being well used and so forth. I mean, there were some complications more with remuneration of physicians, which is not clear with virtual care. It was easier situation with the nurses who were paid on an hourly basis. I mean, there were some issues as well. Not everybody has internet, but by and large, people were very able to use the tablets, and they were very happy with this kind of care. And so it was sort of a mutual win-win, if you will, with people out in the community living at home. They liked being at home as opposed to being in the hospital, and not coming in and having that point of care being done virtually. So, and again, this kind of satisfaction goes both ways. Patients and families are happy, and the nurses tend to be as well. So by and large, those results have been very positive.
Great, thank you. Dr. Keller, do you have any recommendations on how technology might be used to better support pharmacists?
Yeah, I think there's obviously a technology, as Dr. Liu said, can be certainly beneficial, and it can also be problematic. And so I think pharmacy already leverages a number of things that I think have improved efficiencies for a number of technical related elements of the work. And I think we're quite good at utilizing a number of automated dispensing services and all of those things that we're quite used to. But there's a lot around the patient care aspects that are not yet supported well by technology from a pharmacy perspective. Thinking about documentation systems, particularly in community and primary care pharmacy settings, where pharmacists are really reliant on their systems within their pharmacy that aren't necessarily connected to anything else. They're not connected to physicians, they're not connected to other pharmacies. And so there's a lot of duplication and work being done in getting med histories and asking questions. There's no easy way to document care provided within the pharmacy system so that other parts of the team can see it, let alone the other care providers. And so finding ways to connect pharmacy into the bigger healthcare system at a primary care level, I think would be one of the biggest aids to community pharmacy practice specifically, because right now pharmacists do a lot of work and not a lot of that is easily captured. I think it's fascinating that in 2023, the main mechanism of communicating with physicians and nurse practitioners is the fax machine. Like, there's no pharmacy that doesn't have one. And if it's not working, it's a crisis. And there are a number of better ways to communicate that, again, have not been easily worked into the pharmacy workflow. And I think we need to spend some time at a system level thinking about how can we improve communication between providers, and how can we easily transfer information better than the fax machine, more efficiently and more effectively as well. And so I think those pieces also need to be factored in. But I think that technology is actually going to really shift over the next 10 years. If you think about what healthcare is going to look like in 2030, it's going to be much more consumer driven than it already is. And I think one of the biggest shifts you'll see is the notion of patients being consumers of health, and they're looking to have an active voice and be part of their care. But we're also going to have a lot more technological devices, like we all wear watches that tell us everything that we're doing, including if our heartbeat is not normal or whatever the case may be. We need to train healthcare providers that are going to work in the future how to actually analyze the data that all of us are getting in huge amounts like we've never seen before. Healthcare data is everywhere, and patients want it, but they need folks to help them make sense of it. We need to be able to analyze it. We need repositories for it. There's cool technology now with mirrors that when you breathe on them, they can tell you if you have strep throat. The FDA has approved 3D printing for medications, and you can now print multiple medications into a single pill. Once that technology and the tech giants start to see healthcare tech take off, we're going to need an entirely different skill set as healthcare providers. And I'm not sure, as educators, and I say this as an educator at a large institution, I'm not sure that we're really thinking about the impact of AI and where technology is going. We're barely managing in the current state, which is a bit dated. But I think we need to start to think about, where is technology going to take us, and how are we going to train healthcare providers of the future? And I don't know that we're doing that well. And I think we need to really think about how we're going to change our programs, because we're going to get further and further behind if we don't really start to think about how all of this comes together to improve care, and patients are going to start to demand it of us and it won't be a nice day when we can't actually facilitate and really lead that conversation. And so I think there are bigger issues than what technology can do right now.
Before moving on to our next question, I see you nodding, Dr. Alou. I'm just wondering if you want to jump in and add anything.
Yeah, a great point, Jamie. That's exactly what I've been worried about for a very long time. Is we're definitely not training health providers to actually even work in this current year. We've already had several years of patients telling us, "Well, this is possible. Why isn't this working for my healthcare?" And it's not even new technology; it's existing technology. We actually still don't email or text or communicate with patients in that way. I wouldn't want to do that individually as a clinician because of the volume, but the system could actually facilitate support in some of the ways, but less complicated than what Dr. Peter described for home care, for example, for post-hospital care. So the reality is that when we actually have this mismatch, we talk about burnout and moral distress, it's when what we want to accomplish in support of our patients, the system does not enable us to do. We are creating the circumstance for further burnout, for further moral injury, because we're not actually keeping up with what patients and the community needs from us as healthcare providers. And so as a system, but also organizationally, beginning to create changes to meet the current needs of the people coming to us for care becomes a critical piece to reduce the burnout and distress of the workers that we have, because otherwise we're actually forcing them to pull back into an archaic state, which is not meeting the needs of the consumers or what they use on their own in their real lives, which they know this is now artificial and a construct. And so I think there's a real need to work ahead, to plan ahead, and to recognize change. I think one big thing that I hope and I see we change, so we know the demand for care will dwarf our ability to provide it the way the system is going. There's no maybes, we're already there. We're just seeing more, we're getting worse. All of us will need to do more work in our scopes and expanding over time to fulfill the need. One of the challenges that we're seeing right now is the competitive process, looking at it as led by one or led by the other profession. And I think this is a critical weakness. It's the worst flaw we could say, because that's good for businesses that want to compete. All of us working together still can't meet the need. And our desire to work independently was creating those silos by structure, by competition, that's actually burning out our employees and our staffers. And so we actually need to find ways of working together to reduce the stress, to accomplish the goal, and not look to lead individually. In fact, if anybody's leading, it's got to be patients and their family members, because that's why we exist as a care system at all. And we're here to support the need, and how can we do that together? It is more than enough work for all of us, and no more enough change for all of us to struggle through to get there. We can support each other in that process.
Yeah, Dr. Peter.
Hi, yes, I would like to echo my two fellow panelists. A colleague of mine, Charlene Chu, who's very up on every technology, was always saying the same thing. We're behind in nursing education on technology in its various forms. And the other thing that is so important is when these technologies are being developed, to really bring in the providers, to make sure that the technologies are useful and meaningful, and not just another thing to learn that's not quite right. So I've learned a lot from her, talking about various innovations and so on. And I totally agree. We're behind as well. And the ideas of working collectively make ever so much sense. So excellent points.
Well, I have one last question before we move to our audience questions. And I'm going to ask for some, final recommendations, as well as any final thoughts that may have percolated during this panel discussion. To close out, I'm going to ask each of you to share one resource, as well as any other reflections that you think has been particularly good in supporting healthcare workers related to mental health and well-being. And we'll start with you, Dr. Peter.
I don't know if this is a resource, but I happened to click on the World Happiness Report for 2023, and I found it fascinating, because the one thing, and of course, as an ethics person, the findings show that when people are virtuous, they're happier. So people who are altruistic, who are providing care, and so on, they're happier, which makes a lot of sense. That's why healthcare professionals get into the work that they do. However, they have one very important caveat, and they talk about how caregiving is also difficult and caregivers need support. So I found the report excellent in a variety of ways. And so this notion of going back to perhaps why many of us entered into our fields, and how rewarding it can be, but needing that kind of support to do the kind of work that we do is just essential to mental health. So a fascinating report. I've only started reading some of it, but there are lots of insights there.
Thank you. And Dr. Keller.
That report I'm going to go take a look at now. I have not seen it, but it sounds great. I think there's, tons of resources. Sometimes I get overwhelmed by the number of resources, and that's a bit paralyzing. I think that for me, thinking about places that you can go for that connection, I think connection is huge. And so, it's not necessarily a resource that you need to go to the internet for. Sometimes leaving the technology is refreshing. And so thinking about ways to connect with your team or the folks that you work with on a regular basis to build those connections, I think are really valuable, whether that's at the start of a shift, whether that's at lunch or the end of a shift. I think those things are really important. I also like there's a really nice positive psychology website that has some cool exercises that I think you can do as individuals and as teams. I think it feeds into what Dr. Peter was talking about from the happiness report around values and altruism. And it's not the notion of toxic positivity. We hear a lot about that. If you just pretend you're happy, everything is good. It's not embracing that. It's thinking about, even in a bad situation, where's there a silver lining? Or how can I reframe this cognitively speaking to see that there was a learning or a growth or something I could do differently next time? And taking time to slow down and actually reflect on those things to find the positive or a nugget that comes out of even the worst patient encounter or the worst day at work. I think those reframing exercises over time help you move from constantly seeing the negative as your first response, which happens in healthcare and in busy environments. You sometimes forget why you chose to do the work when the work gets hard. We all joined a healthcare profession because we wanted to give back to our communities. We wanted to care for people and to help. But when it gets busy, and in the current state of the world where patient incivility, where people are being mistreated by folks in the healthcare setting, when work is busy and you're making difficult decisions, when you feel like you can't do the work that you're trained to do and you can't do all of the things that are important, that's a heavy load to carry every day. And so I think just finding ways to reframe that, even amongst the chaos or even amongst the volume, there's still some really great work that's being done, and to take time to reflect on those positive moments, because they can help to rewire the neural networks. And over time, you'll see those positive things before you get entrenched in all of the things that went wrong. And over time, I think those are really important to keep us doing the hard work that everyone's doing every day. So again, headspace, meditations, the resources around reframing exercises. I like the silver lining exercise personally, but there's a number there that you can find whatever resonates with you.
Fabulous. Thank you. And Dr. Alou.
Great. So actually build off of what Dr. Peters and Keller were talking about as well there. And a lot of that had to do with meaning that we ascribe to our experiences in that process, right? So what is significance? What is the purpose? What is the outcome? What is our context of giving that care and the distress we're experiencing along the way? So I think there's an opportunity in this process to actually reflect it and ask teams about it and speak to the values and ask about that early on. So organizationally, asking why people do things. Look for ways and contexts that allow that to happen. So as approaches, there's educational contexts that actually bring that up very much. I know that when we do the integrated physical mental health care workshops at the Children's Hospital, looks at the human-centered approach. We actually bring in patients and providers of different disciplines to have a discussion around the challenges that they're having, discussing a particularly fragmented or not functioning process, but how do we come together in solving it? So getting people on the same side of the table, looking to solve it, is actually one of the first, not just coming together, but how you come together to have the conversations. And I think there's ways to validate and then bring people together, because there is shared value, there is shared humanity that drives the process of seeking care and giving care and organizing care. And so I think there's a way to support that conversation early on in the process. As Dr. Keller also talked about, staying just connected. There's a WhatsApp thread that started before the pandemic, which has like 500 physicians on it that literally pings nonstop all day long. And I keep it on mute because it pings too much. But when I need to, I dive in. It validates the community and the context and the solutions that we find for each other all the time. And each of us can do this in our small team, in our large teams as we go forward. Systemically, I've added actually in the chat, you'll see some resources from the Canadian Medical Association, which is the Wellness Resource Hub, particular tools. And so there's peer support programs modeled on Joe Shapiro's program that are now in pilot phases in Ontario from the Ontario Medical Association, as well as other programs that actually are there to support you, and even at the level of distress that somebody's having, different supports that are there. But I think a lot of it boils down to mindful self-reflection, mindful self-compassion, which are courses which, again, bring together your humanity with the work you do and allow you to experience that reduction, the dichotomy that we're experiencing, which causes our distress as well. So there's opportunities for learning, opportunities for connection that bring in the meaning and self-reflection just as much as it does the skills you learn to become better at what you do.
Great, thank you. And I'm not sure, Claire, just to make note of some of those resources that Javed had put into the chat, if we could share them with the audience. I'm not sure if that's possible. I'll also just mention some of our work, Fabulous, thank you. Some of our work with social workers in understanding their experiences around burnout and distress has been related also to long wait lists, difficulties accessing particularly mental health resources and communities for clients, and as a result, seeing their own wait list grow and their own inability to respond how they previously responded in timely fashion to people's concerns, as well as just the heightened complexity of issues that their clients are facing since the pandemic. And one of the rich resource here in Ontario is the Ontario Association of Social Workers. For social workers as well as other healthcare workers, I would really encourage you to just take a look at the educational resources that provide a source of connection as well as a source of broadening capacity. So fabulous. Before we move on to audience questions, I just want to thank our panelists and thank the rich discussion that we've had here thus far. We've had some wonderful questions I see coming through in real time to our audience. We also had some questions submitted earlier in advance from audience members. So to kick us off, one of our audience questions, I'm going to ask, I'm going to open up, throw it up to any of you. Sure. What evidence-based activities can be done to prevent burnout after working long hours and during working hours at home and at work? Anybody want to respond to that one?
I think, Dr. Peter, you'd actually mentioned some of the evidence basis and the weakness earlier.
Yeah, and those were more specific to moral distress. So in those situations, there are some educational strategies and becoming more of a team and so on. Those are helpful in that regard. Burnout is something a bit specific, and it's not something that I have studied, but I think, Dr. Lee, you were talking about finding meaning in work, which I would imagine is, focusing on that would be helpful. And I also see Dr. Keller has her hand up, so she may have a good answer to this one.
Yeah, Dr. Keller, go ahead.
I'm not sure it's a good answer, but it's a start of an answer, I guess. I think when you think about occupational stress and burnout, there are actually a number of areas that have been studied to be predictive of improving outcomes. And there are 6 big ones that are associated with reducing occupational stress and the likelihood for burnout. The biggest one, particularly in healthcare, is workload. And so thinking about the workload, and I think Dr. Peter talked about this as well, resourcing is a big issue. And so really thinking about how we can fix some of the challenges around resources and how we can manage workload. And in pharmacy, this is a significant challenge, has been for a long time, but it's certainly getting worse as we see volumes increase and coming out of the pandemic. And so when you're thinking about workload, we don't have an infinite number of resources, and that's the reality, but thinking about how you can look at times that are more busy, how you can improve workloads at various times or over various periods can help And so there are some creative solutions around workload that's not just about hiring more people when that's not necessarily practical if there are no people. And sometimes economically it's not feasible as well. So there are some things around workload. Thinking about value and reward are also areas that are very predictive of occupational stress and burnout. And reward, we often think about financial compensation, and that comes up, and it's important. Everyone needs to be compensated for the work that they do in a fair and equitable way. But there are other ways that you can reward people that, again, goes back to producing meaning in the work. And so thinking about within your own teams and systems, how do you reward work that's being done? How do you recognize contributions from team members? Those things all go a long way to building connection within your team. Thinking about values, what are the values of the organization? What are the values of the work? And you as an individual, how do they connect to your organization? And the more aligned your personal values are with the workplace values, the more resilient and the less likely you are to have stress and burnout. So there's a number of different ways that you can think about this. And autonomy is actually a really big one. The more control people have over their work environment, the more likely they are to be able to be resilient to the stressful environment. And again, we all have to work for somebody. It's not that everyone can control all aspects of their day, but finding ways to make your own decisions or to prioritize the workflow in a way that works for you, or to take 5 minutes. And I'm speaking as a pharmacist to the other pharmacists, and I imagine this is true in other health professions as well. A community pharmacy can be really busy. There are people there all the time. The phone rings all the time. We often joke that we never get to use the washroom or take a lunch break or do anything that's not got a phone attached to us and we're standing. You actually can. You can go to the back room for 3 minutes and take deep breaths or listen to a song and dance it out if no one's watching you. I mean, whatever brings you joy, but you can take a breath so that you can go back and reconnect and recalibrate with the work. And we need to give ourselves permission to have the autonomy to do that when we need to, because ultimately the worst case scenario from occupational stress and burnout is related to individual mental health and also errors. We know that the more stressed individuals are and the more they're working through burnout, the higher the likely for errors, medication errors specifically, and those can have grave consequences to patients. And so taking the time to slow down and to really prioritize the work and let people know that you're doing the best that you can is actually okay. And we need to normalize those things within our work environment so that we can all continue to perform high quality work in very stressful environments.
Great, and I can continue after you want. Great, and this is exactly, I think, what I was hoping that Dr. Kelly would have to speak about as well, is exactly that aspect of what you have control over, or what you don't have control over. So recognizing in the workplace, there's limitations of what you can do, but there's still things you can do to have agency and choice. And that's probably the most critical piece you have, whether it's in your work environment or after your work environment, in terms of keeping yourself able to be stable and work and well outside of your work hours as well, is the choices you make. So some of the choices are defining what matters most, both in your work, what needs to get accomplished, and what actually is less important, and recognizing when there's resource constraints, what actually will be the first thing you do and what things might not get done today, and communicating that with your team and with your patients and clients as well. And recognizing, people obviously want everything done, and we understand this, but actually sharing this and the rationale and context and the pathway toward getting things done can help you get on the same side of the table when you're looking with a difficult situation. Otherwise, people fill in the blanks with what they believe is going on, and it isolates you from them and creates conflicts that distress you as well. And that's the consequences we all worry about in healthcare's complaints as well. So sharing that information upfront can help you make the difficult rationing decisions that happen at times and the planning decisions that happen at times, but hopefully keep you together with your team and with your patients and clients. And looking at what you do with your time afterwards as well. So one of the things that's come up more recently, just published actually this week, was the phenomenal evidence, for example, for exercise in treating even depression and depressive symptoms. So recognizing when we're feeling overwhelmed, there actually is value in that physical self-care for ourselves as simply a tool to help us manage. Again, 5 minutes, what can you do in 5 minutes at home without equipment? And there is a heck of a lot that is possible in that process as well. Other questions are choices about what we do for each other and ourselves, and that's both in our personal lives as well as in our work lives. So a question that we often asked physicians to look at in our wellness and burnout sessions was, well, what could you do for one of your peers who actually is struggling this in the next 2 days? What small thing could you do that could make things better? Could be sending a text, could be asking how they're doing, could be leaving a muffin on their table. And then the second question is, what could you do to be open for somebody else doing that for you in the next 2 days as well? Because quite often we're used to being so resilient and holding tough and not showing the weaknesses or asking for help. And I think as much as we reach out, it's an openness to receiving as well. And that's a decision that we make. As Dr. Keller described, agency is a critical part. We feel overwhelmed by the system and helpless in the system, and that adds to our burnout and distress. One of the challenges is actually finding ways of having choice in the spheres that are available to us. And there's a heck of a lot there that can open doors to our own wellness and those of our colleagues.
Yeah, yeah, that was, I think, very helpful. And building on what the two of you also said, with respect to nurses, there is some research that shows if they're able to see someone get better, it's helpful. But working in different places, there are some nurses who never see someone discharged or improved. So for them to have some exposure to when things went well and how their efforts contributed to someone getting better. So that has been a huge part of the research, and also gratitude. And the gratitude can be expressed by colleagues as well, because some patients cannot express gratitude. I mean, they might not even be conscious, or they may be, too distressed and so on. So gratitude, expressing it and receiving it is also things that have been found to be very helpful to create meaning in work, in the research that I've looked at.
I love the discussion. Great discussion. I'm gonna read a question from one of our audience members, one of our live audience members. So it says, I recently attended a talk by Dr. Rabia Khan, a social scientist whose dissertation is on burnout in post-grad medical education, where she explored the idea of taking an existential approach and seeing burnout as a part of the health practitioner experience, as opposed to it being a state to avoid. Might this be a helpful reframe for addressing distress related to individual responsibility for mental wellness? And just curious what this panel's thoughts on this perspective are. Anybody?
I can start us off if you think.
For
I
sure.
think it's a great perspective. So recognizing that having moments of suffering, which describes a mismatch of context and where you're coming to the person in the context and your expectations, your beliefs, is a natural part of growth. If we actually always were smooth sailing, never felt that distress, that means there's no growth and change. You're already optimized for your system, and there's nothing that needs to change internally in your views, your perceptions, your adaptation too. But human beings are built for adaptation. Change is part of our living context. And so we push against the edges of our previous ways of doing things and the environment's needs. That's where we feel the distress. And when it's not fully compensated or adapted for, we have the kind of occupational stressors that we experience. And that's normal. It's a chance to recognize what could change to make things better. And so I think it's important to validate and recognize, yes, it's difficult. Yes, we don't want it to be perpetually in this state of a mismatch, because it actually is very hard to exist and grow when there isn't the nutrients to help you adapt to the environment that's growing. But I think it sparked this conversation today about what actually is the future of healthcare, what's the current needs of the system, and how we relate to people when we're giving care, and to each other who are giving care to others. And I think that wouldn't happen had there not been further distress. And we learn through this process. I think bringing it up and actually and it's almost what Dr. Keller was talking about, that silver lining. This is the good that comes with the bad, like Pandora's box, right? You had the bad, but you also had the good that came with it. And this is definitely the good that came with it.
Dr. Peter, I'll ask, this really intersects with your research and your scholarship area. What are your thoughts on our audience members' question?
Oh, I can answer it more in terms of moral distress, which is also seen as something that is a normal thing to experience occasionally. I think last week I was teaching a class, and I gave an example of a colleague who never experienced any kind of moral distress. And it was concerning working with her, because there were situations where she would not react and behave in a way that was supportive to either the patient or the team. So moral distress is something, again, I think just as Dr. Alu was saying, it's not something you want to be in an intense experience every day, every moment, but it's a normal response to things aren't as they could be. What is it that I can help change? What is the system change, and so on? So it isn't something to not ever experience. It's something to work through, and it should be motivating. So to normalize it as a part of being a healthcare professional, just not on a heavy dose every single day. So I think that's the key.
Dr. Keller, what are your thoughts?
So I know Rabia well. We were research fellows at the Wilson Center, and we both use Foucauldian critical discourse analysis as the methodology of our studies. So we were part of the same team and had the same supervisor. So I'll put that out front. So I'm familiar with Rabia and her work, and it's fascinating. So I am a big fan in that. I think that she provides an alternative way for us to think about burnout. And she uses the idea around discourses, and that we've created a discourse of burnout that historically has been present for many, many years. It's just a new label and a new conceptualization, which is how Foucault actually conceptualized mental illness as well over a historical period. So I think what she's done is provided ways of normalizing burnout and helping us think about it as a discourse. And within the different discourses of burnout, there are power relations at play that legitimize certain ways of existing within the world in the context of burnout. And so I think that her way of thinking about it gives us a different angle and context to understand burnout, and to then think about how you can shift or change or exist within the different discourses to enable ourselves to continue to work in the spaces that we need to work. So I actually like her critical look at burnout because it's not a common way that we explore it. And I think it provides alternative ways of understanding it and thinking about how we can continue to move forward and provide care as individuals, but also thinking about it in the context of education, training, and systems. And so I think it's fascinating, and I'd love to see more work looking at burnout from these particular social science lenses, actually, because I think it will add much more to the work that's out there.
Yeah, Dr. Peter, go ahead.
And to add to that point as well, in the moral distress literature, there is also deep concern about how often this comes up in nursing, because implied within it often is this powerlessness. And without a critical examination of, are you really this powerless? Are we really powerless as a profession? Do we have to swallow that up, or can we look at that critically? So within the critiques of moral distress, which are really, really important, we need to examine that feature to try to overturn it where it's relevant. So, I mean, I think that echoes what you're saying about burnout, that we need to be careful about the narratives or the discourses, because they can go unquestioned when they really need to be critically taken apart.
I'll actually add one thing there, actually very relevant to the point when we're talking about the organizational and system effects. So we know that there is a large pressure for organizations to suppress dysfunction within the organization and all that be actually expressed externally. And even, there's employment concerns and legal threats brought to employers when they're whistleblowing about things that are not working right. And I think we have to recognize how that actually is seeking to disempower people, where their empowerment could actually help them engage in acting improvement of the system. So I think that's something we would certainly keep on advocating for, the ability for empowering the providers to change what's actually not working so well.
So we have two questions that are very similar, so I'm going to combine them. One from a current audience member and one that came in advance. So our question in advance, from an advance audience member: how can we engage employers to prioritize staff mental health beyond the focus of self-care? And one of our audience members had sent in something similar that said, can you please point me towards some research or policies that could help us in fighting, that could fight for us to help alleviate our turnover when managers are hurting instead of helping? Anybody want to take a stab at that question?
You want me to start a bit? So I think a lot of what I look at is implementation strategy, and that's a lot of the work that I do in other areas too. And so I think in the end, it's the business case. And so I look at it from a very cold-hearted point of view. So the reality is that if your system can keep on dealing with the churn and the volume and the error rates the way you're going, then there's no compelling reason for management or organizations to change what they're doing. So I think recognizing for the organization, is the current pattern sustainable? Is this going to get them to their other goals? So mapping more clearly what the effects of these things are to their core business mandates. And I think, and dealing often with the C-suite, this is what it is. Like, your project is this, you want to accomplish this. What's not going to happen if you do this? How can your staff not only are they able to participate in the work you want in the way that you want them to do? And so I think recognizing with this process they're facing with attrition of healthcare staff, I think there's a more compelling reason you cannot do your core mandate for existing as an organization without enabling the staff to do X, Y, and Z. So it's a lot more about mapping solutions. And it's, as we described, there's many reasons how burnout and wellness distress is created in healthcare workers, but some of them are more clearly mapped to the processes that exist in organizations that are amenable to the organization to change, what they ask their staff to do, how they ask them to do things, how they communicate. And that's more within the purview of what the organization can change. We know we want them to increase staffing, but that's often not entirely within their own scope, to some degree, but not entirely. And so I think if you're looking to get on the same side as your organization, which is what I think the question is about, how do you help them work with you to solve the challenge? It's about identifying their goals, how the current needs and the trajectory is taking them away from their goals, and what can you do to get the same that you're negotiating like you would in any sort of labor negotiations to show how the goals can be aligned in going forward. And I think that's one of the easiest first things, because in looking at the humanity, people are there for good goals, but when they're not actually helping each other, it's because they don't understand each other's needs, or they haven't seen how their needs are aligned.
Mm-hmm. Yeah, I would also add in very simple terms as well, it's very costly for people to be off sick and turnover and so on. It's very, very costly to an organization, and bringing home some of those facts and figures might be compelling as well.
And I think the reality is that we have to start to talk about it. So as frontline staff that might not be a manager, you might be not somebody that feels like they have the ability to have control. I think starting conversations with your team, meeting with your manager and bringing the issues forward, and bringing it, I think, to Javid's point around from a business case perspective, all organizations need to, whether they're not for profit or whether they're for profit corporations, everyone has a business goal and a mandate to deliver. And I think we need to understand what those are as employees. But I also think that understanding that helps to present the case. And it's not about, meeting with your manager or your team with a laundry list of complaints. It's about working together to find solutions around, here are some of the challenges that we're facing, and here are the things that we're doing well, but here are the things we can't get to, or here are the things we're struggling with that are impacting customer and patient satisfaction. Here's where there's risks of mistakes that can be really concerning. Here's where, we have the biggest crunch and we could benefit the most from additional staff if we can't have it everywhere. And so we can't necessarily get the ideal situation. We live and work in a system that we know is not fully resourced how all of us would like it to be. We could always use more people. That's true in our universities as well. I think that's the reality of how we do the work, but finding ways to meet in the middle and begin the conversation and to talk about stress and burnout and some of the moral injury and moral distress that people are experiencing, and having that start at the ground and moving up, I think is really important, because I think leaders, as they learn more and really are more engaged and transparent, you'll start to see shifts over time, but these things don't happen overnight.
And also, just one quick thing to add, leaders and managers are struggling as well. So, I think sometimes we think they're not, but they are as well. And so having that commonality may also be a place to start.
Mm-hmm. I'll ask one last question that seems to really tie into this conversation that we're currently having. And there's so many wonderful audience questions, so I hate just limiting it to one last one, but I see our time. The last question, how do we not feel guilty for asking for time off or less work when one sees everyone working under intense stress and colleagues are covering double workload? because the imposter syndrome is real, particularly when we're expected to continue to put patients first, work under difficult stressors, be resilient through difficult times, and basically have the answer to everything. So how do we step away without being seen as selfish or not a team player?
I think we just have to empower each other. We all know our own limits, and working past them isn't helpful. And so I think it goes back to the culture of your team, the ability to have these conversations, but everyone needs to be able to take some time off. And in fact, if you can take time off and really disconnect, you come back much more productive in the long run. And so I'm not sure that it's selfish. I actually think it's helpful. And I think it's about how we frame it and how we talk about it. I think, though, one of the take-home messages for managers is, and leaders, and I say this as somebody who thinks about this a lot in my role at the faculty, how do you encourage people to take their time off? How do you set an example? And how do you make sure that you don't ask the same people over and over to do the work? Because it's easy as a leader to go to folks that you know will do it, that will work extra time, who say yes, you do a good job. But there has to be an equitable distribution of work amongst the team so that everyone can actually have those times off. And so you really have to think about it at a management and a leader level if you're in that capacity, so that folks are actually feel like they can take the time off. And then you need to figure out what has to be done and what can wait. Sometimes we have to prioritize the work, and sometimes with somebody being off, you can't do everything, and that's okay. So it goes back to normalizing, having conversations, and recognizing that a rested workforce is a more productive and a safer workforce. And we really need to have that empowerment within ourselves.
I think that's great. I can build off what Dr. Keller was talking about there as well. I think a lot of that comes down to a real radical honesty, recognizing the limits, but we know we're not going to meet all the needs to the fullest extent with the resource we have. We just simply don't have the system capacity for it. We're trying to do the best we can individually in our team and sharing that information. So I often talk about really saying it up front. I know we all need this. We know this will help us function better. When do you need time? When should I take time? And working to negotiate that very openly and explicitly, rather than being worried about doing it individually and worrying what other people think of you otherwise, because we haven't had that open conversation. So breaking down the barriers as much as possible with explicit honesty and sharing, I think really helps. And recognizing, as Dr. Keller mentioned, there will be needs that will not be met. And that's actually normal. But I think also, as she described, the need to reinforce for equitable sharing of resources, because not everybody is as comfortable stating their boundaries or their needs as everybody else. And this is how we take care of each other that we talked about earlier. And that can be support we give each other along the way.
Great. And Dr. Peter, did you want to jump in and add?
Just one small thing. And again, as healthcare professionals, we're so focused on the needs of other people, which is very typical. I think it's a matter of realizing that everyone needs care and support. And to continue to care for other people, we need to do those things like take a day off, which if someone else were doing it, we would say, well, that's completely reasonable. Well, we should be using that same standard for ourselves and normalizing it. So.
Well, before I turn over to Claire, I just want to again thank you, our three panelists. It's been a really rich discussion, and we've covered a lot of ground in this hour and 10 minutes, talking about culture of the team and systemic challenges and funding and the individual experience and organizational context. So you've left me with a lot to think about, and hopefully have also left the audience with quite a bit to think about. Over to you, Claire.
Thank you so much. Thank you so much, all of you, Drs. Ashcroft, Alu, Keller, and Peter, for tonight's incredible discussion. To our audience, for your thoughtful questions and your amazing participation in the chat. And I would like to once again thank our presenting faculties, the Lawrence S. Bloomberg Faculty of Nursing, the Factor and Wentash Faculty of Social Work, and the Leslie Dan Faculty of Pharmacy, for organizing this very important conversation, which I am sure will continue. So I hope everyone takes care of themselves, and I wish you all a good night.